therapies to improve sorry, I lost place. To improve physical function for tendon and skeletal muscle injuries. Tonight, she will be talking with us about her journey as a physician scientist in the current state of orthobiologics and regenerative medicine and PM&R.
All right, thanks for the introduction. I need permission to share my screen.
Yeah, 1 second. Sorry.
Okay. You can edit that out for the YouTube.
Yeah, for sure. Okay, see if you can get it now.
All right, perfect. All right, is it the right direction or the wrong direction?
I think it's in the wrong one.
All right, you can never tell. I don't really need my notes, but
Beautiful.
all right, is that better?
Yes.
All right, can you see my pointer as well?
Yep.
Okay, great. Okay, so thanks again for having me. I am excited to talk to you all. This is kind of a passion of mine, and what I hope that you kind of take away from this is that while things are very exciting, we have a long way to go, and I hope that throughout your training you consider what the evidence shows, especially when you're educating your patients on what your recommendations are and what they should be doing, because they're going to be asking you how to fix them, and it's important to really be honest and understand where things are at. And so I encourage you to continue to read the literature as it moves forward, and to really consider what we know and what we don't know. All right, so I don't really have any financial disclosures related to this talk, but I always tell people that I want to remind them that I'm talking about off-label use of drugs and devices. I guess my intro pretty much had all of my information, but I just kind of wanted to tell you guys just briefly about my path so that you can kind of get an idea of, something that's kind of a little bit different maybe than you would have thought of. But I did my undergraduate in Texas. I grew up in New Mexico, and then I came out to Pittsburgh for my for the MD PhD program here. And then I moved to New York for residency at Mount Sinai, and then I came back for my sports medicine fellowship and then stayed on as faculty here. So the way my kind of day-to-day looks is I do 1 day a week of outpatient sports and musculoskeletal medicine clinic. Particularly, I get a lot of referrals both from inside the department as well as from my other colleagues for ultrasound, and whether that's a diagnostic ultrasound or interventional to do an injection. I don't do a lot of spine care. I do mostly peripheral. Of course, I take care of, non-interventional spine, but with that sort of limited clinic time, I don't really have the bandwidth to do any sort of spine intervention. So I focus more on the peripheral joints. And then the rest of my time is focused on my research, and I do mostly translational basic science research. As we mentioned, one of the things I'm looking at now during my K award is looking at how extracellular vesicles can affect muscle and tendon healing, and in particular how aging as well as sex affects these vesicles and their ability to heal tissues. And then I'm also involved in a bunch of clinical trials as a co-investigator, and they're kind of just listed there. It ranges from doing ultrasound to basically running the clinical side of the trial to just simply giving feedback as a clinical monitor when the subjects have any sort of medical issue during their trial. So it's kind of all over the place sometimes, but it's pretty fun to get to know people as well as to do different things. So I'm going to open it up with a case study. So this is a patient I saw maybe 6 months ago or so. He was a 34-year-old male. He played college basketball at a D3 school. He's had bilateral knee pain for a lot of years. He's had 3 surgeries on each of his knees, and each of his knees had 2 ACL reconstructions. So he's had a lot of surgery, a lot of injuries, And he's tried physical therapy, he's tried bracing, he's tried over-the-counter medications, he's had steroid injections, he's tried viscosupplementation with hyaluronic acid, and some of it works, but not really. And again, he's 34 years old, so he goes to see the surgeon, and they're basically like, well, you look here, he's got a ton of arthritis. He has, just one screenshot of the MRI, but basically you can see there's cartilage kind of up here, but there's a lot of injury here, and you can see that kind of throughout the entire knee. So he's got really bad post-traumatic osteoarthritis, and he's 34 years old. Knee replacements don't necessarily last 60 years. So the surgeon says, wait as long as you possibly can, and then eventually I'll give you a total knee replacement. But go see PM&R Sports. Maybe they have some ideas. So what do we do now? Like, what else is there? And so of course, most of my patients now these days are well aware of what we call orthobiologics, or they talk about stem cells and basically say, doc, what can you do to basically make my knee as good as new? And so what I'm going to do today is kind of talk about some definitions and some treatments that are very common these days, so that you kind of have a baseline to go forward with if you haven't had a lot of background in this area. And so this is my favorite definition of regenerative medicine. It says regenerative medicine replaces or regenerates human cells, tissues, or organs to restore or establish normal function. So I like this definition because it really focuses on the actual function of the tissue, as well as the kind of the regenerative aspect of it. So you can't just say okay, I have made you feel better, but that doesn't necessarily mean your tissues are actually functioning any better. It just means that you don't have any pain. So that is a far cry from what we're actually at right now. So in terms of the strategies for regenerative medicine, they kind of take three different approaches. So the first is this allogeneic organ transplantation. So this is kind of, your heart transplants, your kidney transplants, basically taking someone else's tissue and putting it in yourself, or, I guess nowadays we're putting pig hearts into people as well. Then you have tissue engineering, and this is typically you at least to some degree try to build a functional tissue outside of the body and plant it to have it take over. And it involves a combination of cells, scaffolds, and sometimes some bioreactors to try to get the mechanical properties and the cellular properties to be more close to the native tissue. And then the last thing is, and this is kind of where I focus on my research, is the cellular and acellular therapies. So these are things that kind of harness the body's ability to heal itself, and you're not necessarily putting a whole new tissue in, but you are trying to add cells or bioactive factors that will trigger regeneration. And so I think, for now, the only thing that kind of even comes close to something that I would even consider regenerative medicine that's used clinically at this point is the Macy procedure, that is clearly a surgical procedure. For those of you who aren't aware, so this is specifically for osteochondral defects of a limited size. And what happens is the surgeons will go in, they will take a biopsy from the non-weight bearing portion of the cartilage. So you can see up here at the trochlea or at the intercondylar ridge. They'll take a little plug of cells, they'll digest it and expand it. Then they'll put it onto a kind of a membrane here. The cells will attach, they'll grow, and then they'll take that membrane and they'll cut it to size based on the size of the defect, and they'll stick it in there with fibrin glue. And then, if things go well, the tissue kind of integrates, and it does actually kind of restore the function of the native cartilage. There are definitely limitations to this that I won't go into, but to me, this is the one thing in orthopedics that we're doing that I would consider regenerative medicine at this time. So what I do think that we do more, and especially in PM&R, is focus on orthobiologics. And so the definition of orthobiologics is pretty simple. It's simply biological substances found naturally in the body that help heal tissues. Yeah, so help injuries heal more quickly or help tissues heal more quickly. And, this is becoming a huge market. This is, I think, a little bit out of date even, but, essentially we have this skyrocketing desire and application of orthobiologics, and it's expected, and I bet this is going to be higher in the end, to exceed $8.2 billion by 2026. So, and especially in North America, people are spending a lot of money on these things. All right, so this is kind of the nitty gritty here, but I think it's really important. The FDA regulates some of these products, but it's important to know that none of them are FDA approved. So the kits and devices that we use are typically cleared through the 510(k) pathway, which basically says that this device is similar enough to a previously approved device that we're okay with you using it. And then the other thing to note is that blood products are like, for instance, like platelet-rich plasma, like I'll talk about, are not regulated as human cells, tissue, and other cellular tissue-based products. So they just kind of like ignore it completely for the most part, and focus on it being clear through the FDA pathway, but it's not approved for any particular indication that we're using it for as physiatrists. And this is kind of just, I just have one slide on this, but the different pathways that these cellular compounds can be regulated through. So the first is the easy way, and this is a 361 pathway. And so this pathway can be used if the cells are minimally manipulated, as in like nothing is really added to them to change their behavior. They're not cultured or anything outside of the body, and they're intended for homologous use. And what this means is that you're using the tissue for the same purpose that it was before it came out of the body. So you get into a little bit of gray area when you talk about bone marrow or adipose in particular, because adipose is considered a structural tissue. And if you're not, using it in that way, it really kind of, it hits a gray area. Of course, you can't combine the cells with other materials, so you can't put any scaffolding in it, and you can only rely on the metabolic activity of the cells if they're autologous. And so the main part about this is you can't really claim efficacy or potency when you sell things. So the companies have to be careful about their claims. And then the 351 pathway is the long pathway. And this is if it, a cell-based therapy doesn't meet the other criteria. And so this is, you have to go through the preclinical testing, all phases of your clinical testing. And then because through your clinical testing, you've proven that these products actually do create benefit, then you can, make claims about their efficacy. And so again, this takes a long time, so people really like, or especially companies, really like this 361 pathway, but it's hard to make claims about the actual efficacy of these products. And it's also important to understand why this is really important to know. And that's because none of this is benign. The FDA has really cracked down on companies making false claims on their websites. So this is something I pulled off maybe, I don't know, 3-4 years ago during COVID, pulled off a website. And it was basically this company was offering umbilical cord stem cells to pretty much treat anything you could ever want. So obviously your musculoskeletal pain, for local injections, as well as we can, saying they would do IV infusions of these stem cells for anything from, your headaches to, of course, the most important thing of erectile dysfunction. So there's a lot of false claims out there. There's no evidence to support that these products are useful for any of these things at this point. So beware of those things when your patients come and talk to you about them. And there's been some things in the news about really bad injuries when things are not closely regulated, or people that aren't trained are doing these kinds of crazy injections. So there was an incident where there was a bunch of people that got infections from a bad lot of I believe it was some sort of amniotic derived product. And then, there was people that were getting stem cell injections into their eyes, and they got completely blind rather than having, somewhat lower vision. So these are the things that can happen if we're not careful. So we really have to pay attention. All right, so I'm going to spend a few minutes now kind of going through some of the orthobiologics that are in use, just so you can, when you get to your clinics and you end up seeing it, you kind of have an idea of how they are isolated, as well as how the literature has shown their efficacy or lack of efficacy. So I tend to kind of think of orthobiologics as either autologous or non-autologous products. The autologous products, of course, are products that come from your body itself and are injected back into you. And these are the most common ones that tend to be platelet-rich plasma or PRP, bone marrow aspirate concentrate or BMAC, microfragmented adipose tissue or MFAT, and autologous chondrocyte implantation or ACI, which we kind of talked about earlier. And then there's also non-autologous products such as dextrose prolotherapy has become somewhat popular. Hyaluronic acid has been used for a long time. Bone allografts are, from cadavers are non-autologous. And then there's amniotic membrane products that would also be considered non-autologous. And so I'm going to kind of focus on these kind of like big three today. I could go on and on about all these different things, but I think these are the ones that are kind of most commonly used and I think are the most important to know about. So PRP can be prepared in several different ways. There's kind of two main categories that I think people have settled on to some extent. And these are like the pure PRP method or leukocyte poor PRP, and the Buffy coat method or leukocyte rich PRP. And so both of them start with a soft spin. And I guess I should probably increase the contrast of this picture, but if you can see here, there's a little line here. So at the bottom, you have your red blood cells. Here's the Buffy coat, which contains most of the white blood cells. And then you have your plasma on top. And so then for the pure PRP method, you leave, and the platelets are in here as well. You leave that Buffy coat behind for the most part, and you take this like supernate here, and then you spin it again. And you may have a little bit of red blood cells, and you may have a little bit of leukocytes, but for the most part, the platelet-rich plasma kind of sits in this lower area, and then the other upper part is the platelet-poor plasma. So you can throw that away and keep the platelet-rich plasma. So in contrast, the leukocyte-rich plasma, you keep this Buffy coat layer, and then you spin it down again, and then you can kind of basically take, you kind of do the same thing, but you actually have more of the white blood cells in here. And so you discard your platelet-poor plasma and you keep your platelet-rich. And then it tends to have a little bit more of the red blood cells too, just from the way, if you're trying to get all the leukocytes. The kits are getting pretty good at it, but every kit varies. So yeah, those are the two main ways. There's a lot of different kits. They all pretty much, you just suck it into a syringe and maybe have to kind of move things around a little bit, but a lot of times they're really simple and easy to work with. But so, then what does the data say? And I'm focusing on knee OA today, but you could, look up studies for tendon or ligaments or, kind of whatever you want as well. But just in the interest of time, I'm just kind of studying one study, or actually just one meta-analysis and systematic review. But this came out pretty recently in the American Journal of Sports Medicine, And what they compiled was 40 studies, a total of over 3,000 participants with knee OA. They looked at PRP compared to hyaluronic acid, corticosteroids, and saline. And what they found was there was no difference in adverse events. So it was, pretty safe. And then PRP was at least as effective for pain, function, and stiffness at 6 months compared to the other ones. However, if there was a little bit of leaning one way or another for some things, but if they did a sensitivity analysis to remove the studies that have bias, basically they found there was no difference between PRP and these other treatments. And so that's not to say that PRP doesn't work. It just means that doesn't seem in this particular, in this group of patients of 3,000 patients and 40 studies to be particularly better for pain and stiffness and function than the other more kind of traditionally utilized treatments. Now, the one thing to be said is that, corticosteroids, if you read the literature, there's, some evidence that if you get repeated corticosteroid injections at high doses, that you can have accelerated osteoarthritis. And so that's kind of the main reason to kind of stay away from that. Of course, also you have potential effects if you have severely brittle diabetes, or if you have, really bad osteoporosis, repeated corticosteroid injections can potentially be harmful. And so maybe in some cases, PRP is safer than that. But in terms of overall pain, function, and stiffness, it's really hard to say that PRP is so much better. And I think part of the reason for that is all of the heterogeneity in these studies. So this is taken from that same paper. And I don't expect you to read through all this or anything, but I think what the main takeaway for me here is that there's basically 40 different ways that this PRP was prepared. So there's changing number of spins, how long it spins, what size rotor or speed you were using, if you added an activator to get the platelets to release their growth factors. If you had frozen PRP, pretty much obviously in the US, we're not doing anything frozen, how many doses you gave and when you gave them, whether it was leukocyte rich, leukocyte poor. And then a lot of people talk about the platelet concentration. So how much more concentrated was this, was your PRP in the platelets compared to whole blood? And there's kind of a general cutoff that people utilize to say, what is real PRP, and people will say kind of this 4 times normal blood cutoff. But you can see if you have 10 different ways or 20 different ways to prepare it, it's going to be hard to compare it between studies. So I think that's a lot of the challenge. So then we have bone marrow aspirate concentrate. And so this works, actually it's not that different than PRP. A lot of the Arthrex system, in fact, you can actually use the same centrifuge. But basically, it's a little bit more invasive than getting blood, but you do a bone marrow aspiration, usually through the posterior pelvis, and then you spin it down, separate out as much of the red blood cells as you can and get the other stuff, and then you have your BMAC. And this is one of the things that people often say, oh, I went and I got my stem cell treatment. But it's important to note that, sorry, there's a little typo here, but the BMAC typically contains somewhere between 0.1 and 0.001% stem cells. So there's a lot of stuff in it, may have some similar growth factors to PRP, but it's not a purified stem cell population by any stretch of the imagination. And then the microfragmented adipose tissue. So essentially you do a liposuction on the patient, and you take that tissue and you break it down inside this, cylinder. You actually literally shake this cylinder. It has some metal balls in it, and you shake it up to disassociate the tissue into smaller pieces, as well as kind of separate out the blood vessels. And then you suck the fat and the red blood cells go into the bag, and then you suck out the the good stuff here. And so again, this is one of those stem cell quote unquote treatments. But the studies tend to show that that MFAT only contains 1 to 2% stem cells. So again, this is not a purified stem cell population. And so how do these things work? And the truth is we're not totally sure. But if we want to make a hypothesis, and this, it says MSCs here, but I think that this goes for PRP as well. But the way I think that, that this works is it does several things. So the first is that it modulates inflammatory cells. So it kind of shifts if you're familiar with macrophages, it shifts them towards from M1 to M2 population, which seems to be kind of more anti-inflammatory. They release chemokines that promote repair of any like kind of endothelial or vascular tissue. There's a bunch of growth factors that can trigger either recruitment or proliferation and differentiation of progenitor cells. So this says neurons, but it could be any muscular or musculoskeletal tissue. And then lastly, it can be pro-angiogenic. So it really, like if you have a vascularized tissue like a muscle or something, it could potentially promote new blood vessel formation and decrease fibrosis as a result. But there's limited data to show all of this. So that's a lot of what's going on in the basic science world right now. And so we have quite a long way to go. But just to talk a little bit about the results that are kind of more recent with BMAC and MFAT. So this is a study where they compared BMAC and hyaluronic acid in an interesting way, where they injected one knee with BMAC and the other one with hyaluronic acid if they had bilateral knee OA. And they kind of asked them, like, how's your pain in each knee? How's your function in each knee? So at 6 months, there was no differences. At 24 months, oh gosh, sorry. The VAS scores, which are like the 10-point pain scale, which you can see here, there was a slight, actually, I think I have this backward. There was a slight favoring of the hyaluronic acid. And then if you looked at the Coues quality of life score, there was actually at 24 months, a very slight, but technically significant favoring of the BMAC. So it doesn't really, and again, like this is 0.5, I think it was 1.7 difference to 2.2 difference. And then this of course is small as well. So any difference that you're getting is pretty minimal. And then also if they looked at moderate and severe OA only, there were no differences. And so a lot of people will say now that most of the benefit of these types of orthobiologics is likely to be made in the earlier stages of arthritis. And then this was a study published relatively recently as well. They took 58 patients with knee OA and they injected them with either leukocyte-rich PRP or MFAT and followed them for 6 months. And you can see from these graphs, this is the Coues scale, which is like kind of a pain function and symptom scale, as well as the VAS here. Essentially, you can see them kind of track pretty much the same. So it's really hard to say that any of these are much better than the other. And certainly something like microfragmented adipose tissue is much more invasive to get, as well as much more expensive. So it's at least I find it difficult to recommend these types of treatments. Something like the adipose or even the BMAC above something like platelet-rich plasma. And so I mentioned the kind of variability in PRP in terms of preparations, but I think another thing that is really important and that is really also affecting the outcomes of these trials is that there's so much heterogeneity in the patients, and the patients kind of have two factors of heterogeneity. So they have the fact that they're the donor. So whatever is different about the tissues that they're donating can drive differences, as well as the actual area of injury. Those are very heterogeneous as well. So you kind of have that double whammy of like, how am I comparing things? It's not really apples to apples. And so I think of a lot of different things that could potentially affect how these treatments function. And I think what we really need to do is do really like strong, large studies to kind of be able to parse these out and understand how to optimize our ability to treat people with these orthobiologics. So I think, age is really important. Most people with arthritis are older. So is their PRP as good as an 18-year-old's PRP? We don't know. Are there sex differences? Things like medications. There are some studies that show if you exercise right before your PRP injection, that it actually, because you get more platelet activation, it can be more effective, whether they have, just very mild OA versus severe OA, any other medical issues that they have, if they're smokers, and also, how active they are. Are they going to do that rehab post injection? So I think that all of these play into it, and so it's very complex to decide and to determine who's going to really benefit. So just to quickly summarize, so I think that there's good evidence that orthobiologics do decrease pain, and that if they're administered by the right people, so if you're trained in doing ultrasound guided injections, if you are a physiatrist or at least someone with MSK training rather than a chiropractor, I think that they're relatively safe. But we have a lot of questions remaining. So how do we select the patients that are going to benefit? What is the mechanism of action? What's the best way to prepare them? And then, importantly, how do we manage these patients after the injections? And so these are the things I think that, especially as young trainees, that you all should be thinking about as we move forward, because I think that it's going to become, more and more common, and the better we can do with these treatments, the better our patients will be on. And with that, I will take any questions.
Doctor, we have a quick question about if when you're in a conversation with a patient, they're trying to, they have osteoarthritis or something, requiring one of these options, how would you have the discussion with them if say, money wasn't an option, they're willing to do anything that's not covered by insurance, and you give them the options of steroids versus PRP or viscosupplementation? What is that conversation like? I've heard, physicians talk about, steroids can maybe help increase pain quicker, but you're gonna have to re-get them and may not help, as much long-term, versus PRP might not provide as much pain relief initially, but could help you heal long-term. What's your conversation typically like?
Yeah, so it's kind of like what you just said. I tell them that it's, I've had patients that do really well. I've had patients that don't get benefit. It's a little bit of a crapshoot. I do usually think that if the injuries are more minor, or if they're younger or more active, they tend to do better. So I'm a little bit more eager to push that. If they are bone-on-bone arthritis, I generally try to steer them away a little bit. If they really want to try it, then I think it's relatively safe. And I've had people with like pretty big rotator cuff tears feel better after it. And to be clear, I only do PRP injections. I don't do any of the other stuff. So that's all I've got. But yeah, so it's a joint discussion. And again, it's like if it's a really severe injury, or if they're not able to do a lot of exercise post injection, then I am usually a little bit less optimistic about the efficacy of the orthobiologic. But again, I think with my injection technique, it's pretty safe. So if it's something they're just like, what, I just really want to try this, then I will definitely do. But yeah, it's really dependent on the individual themselves and what their injury is. Like I will not inject steroid directly into a tendon. I will because that's just going to make it worse. But I will inject PRP directly into a tendon. So if that's what they're needing, then I will definitely go towards the PRP. If it's a joint, then it's kind of a little bit more equivocal.
Dr. Bean, I was wondering, just from your expertise, what the evidence looks like for, cartilage versus tendon versus kind of ligament repair with these PRP injections. And then also how often could you say repeat a PRP injection? And is there like a additive effect with kind of multiple injections?
Yeah, that's a good question. So with regards to the different types of tissues, so I would say that I haven't seen any evidence to suggest that injecting PRP is going to do anything to heal your cartilage, period. There's like the MRI studies are pretty clear that it's not actually giving you thicker cartilage at this point. It might help your pain and decrease inflammation and make you feel better. With tendon, I've seen it kind of stimulate some like tissue. I wouldn't call it like full on like repair. But maybe I've seen a defect get a little bit smaller, or like to kind of, get a little bit of tissue inside the tendon. But again, I haven't personally seen a tendon go from like a significant tear to perfectly healed with these treatments. But I have seen people go from in a lot of pain to feeling a lot better. So I really focus on the fact that it's going to be pain relief versus completely healing your tissue. And then to your second question about the timing, and that's something we really don't know. I haven't seen any data to suggest that repeated injections are better. There are a lot of people out there who will say, come get 3 injections 2 or 3 weeks apart. I personally only do 1 injection, and then I wait about 3 months. And if they get about, if they get 50% relief, then I'm happy to try another one. If they get no relief, I'm a little hesitant because I'm just not convinced that the second time around is going to be any different. Although I have heard anecdotally that patients do sometimes have better response the second time around. But there's been literally nothing to give us evidence one way or another about how many injections is appropriate. So I typically start with 1 and go from there. But again, that is very clinician unique to each clinician. So
Thank you.
So Dr. Bean, with the variability in the preparation for PRP, how soon do you think the field will be able to standardize that process or get like some sort of guidelines out so that at least the research can be a little more less variable?
Yeah, so I don't think we don't have any chance to standardize it because these companies are going to push their products and everyone's going to choose a different one. With regards to the research world, there have been several publications about, calling for minimal guidelines for reporting, so that if you are doing research, you have to report like, was it leukocyte rich? Was it leukocyte poor? Or, what was your platelet concentration? Like what did you do? Like all those things that were in that chart, like you have to report those. And so that is, pretty much if you ever do research, you should, like, if I ever review a paper and they haven't done that, then that's my first thing. I'm like, you need to report this information. But in terms of standardizing, I don't know. I think it's gonna be really challenging just because we kind of put the cart before the horse and we've started using it clinically before we've actually successfully done the research. It may be that eventually we get to the point where we realize like, oh, at least like leukocyte rich might be better than leukocyte poor for, for tendon, or the other way around for joints. But I think the data has just been so weak to date. I don't really have a ton of confidence in it, to be honest.
Okay, thanks.
Dr. Bean, kind of on a slightly similar note. This might be its own kind of like Pandora's box, but in terms of kind of like standardizing treatment, is there any progress or like thoughts towards not using autologous PRP, but using like donors from people that are like quote unquote healthier or younger, or might have like, I don't know, more like ideal platelets in a way compared to like someone that's like older or more sickly?
Well, we don't have any data to suggest that that would be any better. I mean, I have an inkling and there's some preclinical stuff, but there's nothing strong enough to really move the field that way. And then you also create a whole nother issue if you're doing donors versus autologous. Like, you know, you can have immune reactions to that. So that could be somewhat risky, and typically requires more oversight from the FDA. So I think, and I also, you know, to be honest, I think patients like the idea of like getting their own stuff. I think that's really appealing to them. So I don't know if I really see it going that direction with like these injectables, but it may, I could be wrong. Certainly I'm personally doing that research to just kind of, and not necessarily for PRP, but for extracellular vesicles, to try to show that there are differences between young and aged, and that we really do need to focus on understanding what the mechanism is and what are the important parts of it, so that we can identify what makes good PRP or what makes bad PRP. So I think it's definitely the direction we need to go, but I think it's going to take a while for sure.
Kind of as like a follow-up, if you have like a patient that is planning to get PRP in like the next year or two, is there anything that you tell them to do for their own lifestyle, like any specifics to like kind of optimize that process?
No, not really. I mean, I certainly tell them not to, you know, I tell them stop smoking. And then I think the biggest thing I do is I always encourage them post-injection to really get into a really good PT program. Because that's a whole nother variable that people haven't really studied. But like in terms of like anticipatory guidance, I don't really have that much other than just kind of your general healthy measures. But I think that that would be a really exciting area of research to kind of look into to see, you know, once we know what the good stuff is, how do you prepare yourself to give good stuff? But we don't know the answer to that yet.
Thank you.
Dr. Bean, I was also
Sorry about that.
wondering, oh, sorry. I was also wondering, so we talked about how the meta-analysis was showing PRP was at least as effective as steroids. And you kind of talked about all the, you know, the kind of baggage that comes with steroids and all the side effects. So I was wondering, one, has there been any like kind of alarming side effects that have been identified with a lot of these injectables? And then also too, like what is kind of like the onset and timeline of relief that patients can expect from these?
Yeah, so in terms of side effects, you know, I think the main thing is sometimes people have a little bit, or sometimes significantly more pain for a week or two. But outside of, you know, as long as you're doing everything safely and sterilely, you know, obviously infection is always a possibility whenever you're putting a needle into someone. So I think that, to me, that's the biggest risk if you have someone who knows what they're doing. And then in terms of timeline, I typically tell patients not to feel any distress if they don't get any relief until at least the 6-week point. And then, you know, if the data kind of shows that you're kind of going to hit that point of like your maximum relief at about 12 weeks. So that's kind of why I say, like, let's wait 12 weeks till we consider a repeat. But yeah, everyone's kind of different, and so that's why I kind of give them the you might not feel better for 6 weeks, but I would say most of my patients usually start to feel better in that kind of like 3 to 4 week range. But again, everyone's different, so I try to, and I can't predict it.
Yeah.
So I try to just give them I kind of try to give them the worst case scenario so that they don't get upset with me.
That's fair. I guess how long can you maybe expect results too, kind of after that?
Yeah,
Like
again,
to
like
last, I
everybody,
guess.
yeah, everybody seems like pretty different. I guess I always tell them, I usually say we hope typically that steroids will work for about 3 months. And so then I always say, like, I hope, first, of course, with any injection, I always hope that you stay pain-free forever. But I usually say, like, kind of 6 months to a year is what we're kind of hoping for. But I've had people, again, like do really well after just one injection for up to a couple of years. So I think it's again like pretty variable, and it's all dependent on their strength, whether they're doing PT, what their baseline function is. All of that kind of matters. So it's tough to predict, but yeah, I usually kind of say that like 6 to 12 month range is what I'm really hoping for, if not longer. Good questions.
Does anyone have any other questions?
Yeah, if not, I think it's good to end there, to respect everyone's time. And otherwise, yeah, Dr. Bean, thank you for talking with us today. Yeah, unless Hunter, you have anything else to say, I hope everyone has a good rest of their night.
Yeah, thanks for having me, and let me know if anyone has any questions. I'll throw my email in the chat before everyone takes off. So feel free to reach out, and good luck with school, and hopefully I'll see you guys. I'm not going to go to the academy meeting, but I'll be at AAP if anyone's there.
Cool. Thank you so much for coming to share your knowledge with us.
Of course.
Thank you.
All right, have a good night.
Have a good night, Dr. Bean.
Bye-bye.